Intensive Care Unit. I'd like to invite the following chairpersons to join us on the stage. Dr. Jyoti Mannari, Professor in the Department of Medicine, Pramukh Swami Medical College. Dr. Chirag Modi, Consultant Physician in Anand. Dr. Chirag Patel, Consultant, Microbiology, Anand. And Dr. Bhavin Patel, Pulmonologist in Vadodara. Thank you. I'd also like Dr. Jyoti Mannari to please introduce the speaker for the session.
Thank you, organizers, for calling me to chair this session. I introduce Dr. Prayag. I've been knowing Dr. Shirish Prayag because he was the one who had helped us set up the critical care unit years back. So now I'm glad to invite Dr. Shirish Prayag's son, Parikshit Prayag. He is the American Board Certified in Internal Medicine, American Board Certified in Infectious Disease, current designation Consultant Transplant Infectious Disease, Dinanath Mangeshkar Hospital, Pune, Director Infectious Disease Fellowship and Training Program, DR Center for Excellence in Infectious Diseases. So, highlighting, he is one of the very few trained transplant ID consultants in India. So, we'll be very glad to have Dr. Prayag, who will be talking about CRAB in the ICUs. Thank you, sir. Please continue.
Thank you, ma'am, for the kind introduction, and good morning, everyone. It's my great pleasure to be back in this area. In 2013, actually, we got married in Anand, so it's always a great pleasure coming back to this part of the country. So I'm going to be talking about management of carbapenem-resistant Acinetobacter infections, and all of us who have worked in the ICU, we all know the kind of problems that Acineto brings with it. We keep talking about E. coli and Klebsiella, but Acineto actually has far higher resistance numbers if you consider the ICMR data or if you consider the national data. In most hospitals in the country, if you look at hospital-acquired Acinetobacter, then the resistance is more than 90%. Even in the ICMR data, the National Center for Communicable Diseases actually publishes this data every year. In their surveillance report, wherein they take many ICUs and sites across the country, public as well as private sector, the carbapenem resistance for Acinetobacter is almost 90%, whereas that for Klebsiella is around 50% in most hospitals. So by far, the most resistant bug in our settings is Acineto. Now, how much of a burden it is, it will vary from one ICU to the other. But the resistance burden for Acinetobacter is by far the highest across the country. So if you look at the big fours that we say in our ICUs, E. coli, Klebsiella, Acineto, and Pseudomonas, Acineto, like I said, has far higher carbapenem resistance numbers. And that is what makes it very difficult to deal with. Plus, as we go along, you will realize that some of the drugs that we use for Enterobacteriaceae, for example, the combination of ceftazidime, avibactam, and aztreonam, this is not a combination that works for Acinetobacter. So really, our options are very limited when it comes to carbapenem-resistant Acinetobacter. So what makes Acinetobacter so resistant in our settings? This is a simple way of describing what happens with gram-negative bugs. So these are our beta-lactam antibiotics. So these are our penicillins, cephalosporins, carbapenems, or aztreonam. They enter through the porin channel and bind to the penicillin binding protein. Now during this journey, there could be resistance at various places. One is what is known as a modified porin channel. So your beta-lactam won't be able to enter at all. Then you could have efflux pumps which kick the beta-lactams out in the opposite direction. And the most important mechanism of resistance for Acineto is production of what are known as beta-lactamases. So just as we have beta-lactams, so like I said, penicillins, cephalosporins, carbapenems, and aztreonam, just as we have beta-lactam drugs, we have what are known as beta-lactamases. And these are enzymes that are going to destroy our beta-lactams. You could also have modification of the penicillin binding proteins, what we are increasingly seeing in our E. coli. But if you look at Acinetobacter, by far the most important mechanism of resistance is the production of beta-lactamases. So like we said, beta-lactamases are enzymes which destroy beta-lactam drugs. So what is the substrate for them? So anytime you talk of an enzyme, what we must think of is what is the class that it belongs to and what is the substrate that it is destroying. So which beta-lactam is it destroying? Is it penicillins? Is it cephalosporins? Is it aztreonam? Is it carbapenem? And then we'll go and see a few of the important Acinetobacter enzymes, because I'll be focusing only on Acinato this morning. So enzymes which destroy your penicillins are going to be known as penicillinases. So some of the oxas are penicillinases. So they will not bother your cephalosporins, they will not bother your carbapenems. And that's why most of the times you may not even notice them in clinical practice. If you have enzymes which destroy up to the 3rd generation of your cephalosporins, which means that ceftriaxone and ceftazidime are destroyed, but cefepime, which is a 4th generation antibiotic or a 4th generation cephalosporin, is spared. And then you may have seen ESBL reports many times in the ICUs. Almost 60-70% of our ICU burden is from ESBL. So these are extended spectrum beta-lactamases. These are enzymes which destroy all the cephalosporins, so right up to the 4th and 5th generation. 5th generation cephalosporins, mind you, are in their gram-negative spectrum like the 3rd generation. So when you talk of ceftaroline and ceftobiprole, they are really agents which have enhanced MRSA coverage. But when it comes to the gram-negative spectrum, they are like your 3rd generation cephalosporins. So ESBLs are going to be destroying all your cephalosporins. And then last but not the least, you have carbapenemases, which destroy carbapenems. So, and this is the more formal way of classifying it. This is the Amler's classification. So anytime you have an enzyme which is given in your PCR test or molecular test, what is important to know? What is the Amler's class to which it belongs? What is the substrate that it destroys? And which beta-lactamase inhibitor destroys it? So just as we have beta-lactamases, we have BLIs or beta-lactamase inhibitors. So with this introduction, let us see a report like this. So this is an Acinato in blood cultures. So this is resistant to piperacillin tazobactam, resistant to meropenem and imipenem. Why have they not given ertapenem? Because ertapenem is inherently resistant. So when you think of ertapenem, ertapenem is inherently resistant to Pseudomonas as well as Acinetobacter. So your lab will not test for ertapenem. So imipenem and meropenem are resistant. Colistin is intermediate. So now in the last 3 years, we have moved to using the intermediate and resistant nomenclature for colistin. On reports, you will no longer see it as colistin sensitive. You will see it either as intermediate for those labs which follow the CLSI standards. There are basically 2 standards, CLSI, which is the American standard, and UCAST, which is the European standard. So for labs which follow the CLSI standards, you will see it as intermediate or resistant, which means if the MIC is less than 2, they'll call it intermediate. If it is higher, they will call it as resistant. So colistin here is intermediate, amikacin is resistant, cefepime is resistant, and minocycline is sensitive. So looking at this report, we know that this is a carbapenem resistant Acinetobacter. So what are the enzymes that it is likely to produce in our settings? And how do we detect them? So there are various ways of detecting these enzymes. You could do a Carba-R test. You could do a BioFire panel. Although these tests are typically not very useful when it comes to Acinetobacter enzymes. These tests are more meant to look at enterobacterial enzymes. So let's look at what the Acinetobacter enzymes are. So if you really had to remember 5 enzymes of Acinetobacter, these would be the most important enzymes in our setting. And the problem is that none of these 5 enzymes are inhibited by any of the BLIs that we use in clinical practice. So NDM and Acinetobacter oxas, that's a very simple way of remembering Acinetobacter enzymes. So NDM and Acinetobacter oxas. Mind you, oxa 48 is an enterobacterial oxa. So it's an oxa which is produced by E. coli, Klebsiella, Citrobacter, Enterobacter, Serratia, and so on. It's not a common enzyme of Acinato. So Acinato has its own peculiar oxa enzymes. So simply, if you can remember this statement, that the most important enzymes which are produced in our settings by Acinato are the New Delhi metallobeta-lactamase, which we all know is a class B zinc-based enzyme, and the Acinetobacter oxas. Now the problem is that none of the BLIs that we have in clinical practice right now, clavulanates, sulbactam, tazobactam, avibactam, and also what they have in the US, relebactam and vaborbactam, none of these 6 BLIs can inhibit any of these enzymes, which means that I have no BLI which can take care of any of these enzymes. Probably in the next 2 or 3 years, we will have sulbactam, durlobactam, and durlobactam is now the first BLI which has been shown to inhibit the Acinetobacter oxas. But at this point of time, we don't have any BLIs which can take care of these enzymes. So NDM as well as the Acinetobacter oxas, 23, 24, 51, and 58. Even amongst these, and I'll show you some of our own data and publications, even amongst these, NDM and OXA23 are by far the most important enzymes when it comes to Acinetobacter in India. So again, in a nutshell, Acinetobacter, the main resistance mechanism is production of carbapenemases rather than porin mutations or efflux pumps or PBP mutations. The main mechanism of resistance is production of what are known as beta-lactamases. And amongst these, the main enzymes are NDM and Acinetobacter oxas. And if you really had to remember only one oxa for Acinetobacter, it would have to be oxa 23. So like I said, none of these enzymes are inhibited by avibactam. Also remember that Aztreonam has inherent resistance. So Acinetobacter has inherent resistance for Aztreonam. It's like giving tigecycline for Pseudomonas, right? There is something known as inherent resistance, that inherently this antibiotic will not work for it. So Ertapenem, Aztreonam, these are antimicrobials which have inherent resistance for Acinetobacter. And hence combining Ceftazidime avibactam with Aztreonam has really no meaning or no activity when it comes to our carbapenem resistant Acinetobacter infections. So remember that this is not a combination which is supposed to work for Acineto. It is primarily meant to be a combination for your Enterobacteriaceae. Even for Pseudomonas, there are many which I won't go into, but even for Pseudomonas, the combination has only at best a 60-70% chance of working when it comes to a carbapenem resistant Pseudomonas. So remember, Ceftazidime avibactam plus Aztreonam is not a combination which is meant to treat your Acinetobacter infections, and we don't have a BLI which can take care of the Acineto enzymes, NDM and oxas. So this is what I was talking about. Even amongst the Acinetobacter enzymes, what we primarily have, and our data correlates with what Dr. Balaji has published from the Christian Medical College in Vellore. So what we have here is oxa 23, oxa 51 and NDM. These are predominantly our most important enzymes when it comes to carbapenem resistant Acinetobacter. And the harder part is that non-beta-lactam antibiotics also fare very poorly in our setting. So if you look at the other options for Acinetobacter, so fluoroquinolones, aminoglycosides and tetracyclines, even amongst our other options, we have pretty high resistance rates. So when it comes to amikacin, minocycline, tigecycline and fluoroquinolones, the best bet perhaps is something like minocycline or tigecycline. Now there are some hospitals which have higher tigecycline susceptibility rates. There are some centers like what we have in Pune which have higher minocycline susceptibility as against tigecycline. The important part here is that there are different resistance mechanisms for minocycline and tigecycline. So if your lab is telling you TG-MICs, do ask them minocycline MICs when it comes to Acinetobacter. You cannot extrapolate the MICs of minocycline from tigecycline and vice versa. There are different mechanisms of resistance. So for example, TET-B mediated resistance is more common for minocycline, whereas TET-X mediated resistance is more common for tigecycline. So if my lab tells me that it's tigecycline resistant, I will not assume that it is minocycline resistant. If my lab tells me that it is tigecycline resistant, I can assume that it is doxycycline resistant for Acineto, but I cannot assume that it is minocycline resistant. So remember that amongst the tetracyclines, you cannot extrapolate the susceptibility for one from the other. So, and vice versa, if they tell me that it is minocycline resistant, I cannot assume that it is tigecycline resistant. So amongst all the non-beta-lactam choices that we have in our settings, minocycline and tigecycline, and I'll come to sulbactam, these are perhaps our best choices when it comes to Acinetobacter. So how do we place all these drugs? So broadly, if I asked you that, what are the drugs which you will use for carbapenem resistant Acinetobacter, you will say that it could be polymyxins, minocycline, tigecycline, sulbactam, meropenem. These would be the drugs that you will use in combination. So let's, for the next 10 minutes, look at where exactly do we place them. Do I use polymyxin or plus meropenem, or do I use polymyxin plus sulbactam? How do we place all that? Or we just pick random antibiotics from a basket like we pick chits. No, that's not the way we do it. So there is a method to this madness. So if you look at carbapenem resistant Acinetobacter infections, the first and foremost question that we must ask is that are we giving this patient monotherapy or combination therapy? It's a question that has been debated for a long time. If you look at the international consensus guidelines on polymyxins, which were published almost 4 to 5 years ago, there was a panel of 25 experts, and they were divided 13 versus 12 when it came to Acinetobacter. When it came to Enterobacteriaceae, all 25 felt that we should give combination therapy, because there are large meta-analyses which have shown that for carbapenem resistant Enterobacteriaceae, combination therapy is much better. What about Acinetobacter? So for Acinetobacter, this was long debated. In their most recent guidelines, IDSA has sort of put this debate to rest, in which now they are saying that we do encourage the use of combination therapy. And these are all the studies that have compiled which have gone into making this recommendation. But you will see that these are not groundbreaking studies. These are small retrospective experiences. But in these studies, combination therapy has helped. So which led the IDSA to make this statement last year that we do favor the use of combination therapy for carbapenem resistant Acinetobacter infection. So out of all the confusing things in ID, maybe one question or about Acinetobacter, The one thing that we do have a little bit more clarity on now is that we are going to be using combination therapy for our carbapenem resistant Acinetobacter infections in the ICU. Now, if you have a ward patient, let's say, who has a line-related Acineto and he has good MICs for minocycline, maybe you can try minocycline monotherapy. Again, it's not a very sidal drug, but maybe that can be an option. But in the ICU, definitely the panel is recommending the use of combination therapy as against monotherapy. So this is the first question. That brings us to the second question. What is the combination that we are going to be using? We agree that combination is better, but which is the combination? Is it poly plus meropenem? Is it poly plus minocycline? Is it poly plus tigecycline? Is it polymyxin plus sulbactam? Is it minocycline plus sulbactam? So which is the combination that we are going to be using? Now, here again, we have two very, very good studies. Perhaps the best studies on combination therapy in Acinetobacter are on this subject. They have both shown, there are two trials. One was the Overcome trial and one was the IDA trial. They have both shown that the use of polymyxin plus meropenem really does not offer anything above polymyxin monotherapy. And the same holds true for our Enterobacteriaceae. The kind of MICs that we see in India, especially with the production of NDM, the New Delhi metallo-beta-lactamase, we have very little evidence to support the usage of polymyxin plus meropenem. So really, polymyxin plus meropenem in our settings doesn't add much above polymyxin monotherapy. So while we all agree that combination therapy is the way forward for Acinetobacter infections, especially in the ICU, we also agree that this combination should not be polymyxin plus meropenem. So now we are confusing it a little more, right? We are saying that combination should be used, and then we are saying that polymyxin meropenem should not be used. And that's where we go to our other drugs. So then if we are not using polymyxin plus meropenem, what are we using? So again, this is the Overcome trial and this is the IDA study. Both have shown that combination with colistin and meropenem was not superior to colistin monotherapy for pneumonia or bloodstream infection. And that is where predominantly you find Acinetobacter, pneumonia and bloodstream infections. Sometimes you do find it in the setting of urinary tract infections. Very rarely will you find it as a part of intra-abdominal infections. The other unique problem in India is finding Acinetobacter in the setting of post-neurosurgical infections, which makes it even harder to treat. So there is a decent amount of data which shows that in the post-neurosurgical settings, Acineto is an important pathogen. So coming back to our questions, we agree that combination therapy should be used. We also agree that polymyxin, either polymyxin B or colistin, plus meropenem is perhaps not the way to go about it. So then, what are our options for combination therapy? Which means that now I am left with drugs like minocycline, tigecycline, sulbactam, or triple combination regimens. So now there was this in vitro study a fairly long time ago, almost 6, 7, 8 years ago, which said that the triple combination of high dose sulbactam, read every line of it, the triple combination of high dose sulbactam with high dose prolonged infusions of meropenem with high dose of polymyxin, so good dose of polymyxin regardless of the renal status of that patient, resulted in rapid eradication of Acineto. So there are some experts who use high dose sulbactam, so 12 grams of sulbactam every day. And unless the patient's GFR drops below 30, really you don't have to dose adjust sulbactam. So as long as his GFR is above 30, then you can use something like 12 grams of sulbactam daily. So which means you either use it as 4 grams every 8 hours or 3 grams every 6 hours. The good part of our settings is that we do get plain sulbactam. Unlike in the US, sulbactam, where sulbactam is available only as a combination with something like ampicillin. So we do, and that's why they have used ampicillin. The ampicillin here really has no role. So what we are using here is the sulbactam part of the ampicillin. Sulbactam is an interesting BLI. It is amongst the currently available BLIs, it's the only BLI which has its antibacterial properties itself. All the other BLIs like tazobactam, avibactam, relebactam, vaborbactam, they are only beta-lactamase inhibitors. They themselves do not have any anti-beta-lactam activity. So sulbactam in that sense is also an antibiotic, apart from being a beta-lactamase inhibitor. But the antibiotic part is largely restricted to Acinetobacter. So sulbactam itself also has anti-Acinetobacter properties. So again, coming back to a high dose of sulbactam in combination with meropenem and polymyxin. But what about our own Acinetos? We said that, I showed you my data which said that our own enzymes are NDM and OXA23. So anytime it comes to gram-negative infections, we have to try and answer the question what works in our settings, because our enzyme epidemiology is very, very different. In the West, they don't have much of NDM when it comes to Acinetobacter. It's predominantly the OXAs. So this is a study which shows that minocycline plus sulbactam actually resulted in the greatest in vitro efficacy. So minocycline plus sulbactam in our settings is a good combination to use. What two important meta-analyses have shown is that if you use combinations of polymyxin plus sulbactam plus or minus tetracyclines, these are very good regimens to use for Acinetobacter. So again, we are excluding meropenem, remember, from the regimens. So poly plus meropenem is not a great, poly plus meropenem is not a great regimen. If at all you are a big fan of meropenem, try and use it as a part of a triple combination. But again, in settings where NDM predominates, see really what reduces the efficacy of meropenem in combination therapy is the presence of the New Delhi metallo-beta-lactamase. So in NDM predominant regions, non-meropenem containing combination regimens are a much better way to go about it. And here we have the options of sulbactam, tigecycline or minocycline. Of course, not to use both tigecycline and minocycline, but polymyxin plus sulbactam plus or minus either minocycline or tigecycline. Again, this shows the same. Therapeutic regimens including high-dose sulbactam in combination with additional agents including colistin might be one of the promising options for the treatment of MDR Acinetobacter or XDR Acinetobacter. That leads us to, in the last 5 to 7 minutes, that leads me to discuss a few things about the PK/PD aspects of these drugs that we are going to be using. So what about polymyxins? Now for polymyxins, the important part here is that my previous speaker showed the slide in which the pharmacodynamic target for polymyxins was based on the AUC-MIC ratio. So what is the AUC-MIC ratio that I am looking for polymyxins? So what is AUC? It's the area under the curve divided by the MIC. So if you look at AUC-MICs, and I'll show you a simple way of how we use this in clinical practice. So normally when we read this literature, we think of it as something which exists only in theory. We can use it at the bedside. So how do I use my AUC-MIC ratios at the bedside? So for that, the first thing I must know is that what are my AUC-MIC targets? The targets for Acinato bloodstream infections are around 20 to 25, whereas the targets for pulmonary infections are more than 100. So there itself, it shows me that pulmonary infections are not very forgiving when it comes to the usage of polymyxins. Polymyxins fare poorly in pulmonary infections. Here my pharmacodynamic targets are much higher. So my AUC, I am looking to achieve an AUC-MIC of more than 100. If I do have access to therapeutic drug monitoring, can I calculate my AUC? Yes, I can. It's very simple. So if let's say we do that in our hospital, we do therapeutic drug monitoring for colistin. So if I do TDM drug levels for colistin, then a drug level of 1 roughly correlates to an AUC of around 24. So which means that if I do send colistin levels, the colistin levels come back as 3, I can roughly say that my AUC is around 70 to 75. And you divide that by your MIC, you do get AUC-MIC ratios. So these are just the last 8 patients for whom we have done polymyxin levels. Look at how variable they are and look at how poor they are, especially when it comes to patients who have augmented renal clearance or even normal GFRs. So the moment the creatinine is below 1 or if the GFR is more than 80, polymyxin levels really fare very poorly. So look at the kind of AUCs that these patients are generating. I said that we can multiply by 25. So look at these AUCs. They are producing AUCs anywhere between 5 to 10 to 100. So the polymyxin drug level, if you multiply by 25, you will get a rough idea of the area under the curve. So really we are generating very poor AUCs, especially when it comes to colistin. So one thing is clear that if you are treating non-urinary tract infections, polymyxin B is a much better drug than colistin. It generates much better pharmacodynamic data. Also, it's not a prodrug that needs to be converted into its active form. So there are many differences between colistin and polymyxin. The protein binding, the fact that one is a prodrug, the fact that colistin takes time to build levels. It takes at least 7 to 8 hours to build levels and start acting. And the pharmacodynamics are also poorer. So I get much better AUCs with polymyxin B. So for all these reasons, polymyxin B should be preferred over colistin in non-urinary tract infections. In UTIs, of course, polymyxin B does not have good penetration into the urinary tract. So again, I am having very poor AUC-MICs with polymyxin B. So if you are, and that's one of the main reasons why we are advocating combination regimens now with polymyxins. What about minocycline? Again, I need AUC-MICs of around 15 to 20. So we should not be fixated on the dose of 200 loading and 100 milligrams BD. If you have patients who have augmented renal clearance, or if you have MICs more than 2 for minocycline, definitely we should be using higher doses. If you again look at the latest IDSA guidelines, what they are saying is that for resistant infections, for MDR infections, minocycline should be used as 200 milligrams BD.
They are even advocating up to 350 milligrams BD per day, but that I think for our patients, a lot of them are slow metabolizers for tetracycline. So with our patients, the toxicity becomes an issue. So definitely try and use higher doses if you have augmented renal clearance, XDR or MDR isolates, or patients who have minocycline MICs more than 2. So 200 milligrams BD can be used. And sulbactam, like I said, again higher dosing should be used. So we are looking at 12 grams per day of sulbactam when used as a part of a combination regimen for Acinetobacter. If you have GFRs less than 30, you can dose adjust that. So the dose adjustment really starts only below GFRs of 30. Other than that, you can use sulbactam safely as a dose of 12 grams per day. Now I said that sulbactam, durlobactam will make its way eventually to India. The good part here is that durlobactam also takes care of class D OXA enzymes of Acinetobacter. So OXA 23, 24, 51, 58, what we talked about. We said that there is no BLI right now for them. So here is your BLI for them. Durlobactam does take care of OXAs for Acinetobacter. But the problem in India is always going to be NDM. So durlobactam, sulbactam, durlobactam, even if it comes to India, NDM producing isolates will still be a problem. If you have an OXA 23 producing isolate, it will be good. NDM producing isolates, it will still be a problem. But again, it's something better than what we have right now. Eravacycline which is being used in the Western world, is like a better version of minocycline or tigecycline when it comes to Acineto-MICs. So a lot of TG and minocycline resistant Acineto isolates still remain susceptible to eravacycline. So eravacycline and sulbactam, durlobactam are two good drugs to look forward to when it comes to Acinetobacter. So this was the phase 3 study that they did recently for sulbactam, durlobactam. What about cefidericol? Cefidericol, the advantage here is that cefidericol is not affected by the New Delhi metallobeta-lactamase. So that makes it attractive in our settings. So NDMs cannot hydrolyze cefidericol. But at the moment for Acinetobacter, it's being advocated as combination therapy. It may be a better drug for Pseudomonas and E. coli. For Acineto, it's currently being advocated as a part of combination therapy. And eravacycline I talked about, it's like a better version of minocycline and tigecycline. So last couple of minutes, I'll end by showing you this case. Patient with post-neurosurgical meningitis and CSF is showing or growing Acinetobacter, and it's resistant to meropenem, colistin and minocycline. So this is a nightmare because, like we said, ceftazidime, avibactam, aztreonam cannot be used. Why? Because avibactam does not destroy any of the Acinetobacter carbapenemases. Aztreonam does not have any activity against Acinetobacter. Aminoglycosides here are resistant. They also have not such great penetration into the CNS. So which leaves me with our usual options: colistin, polymyxin, meropenem, minocycline, tigecycline, sulbactam. The problem here is, apart from the fact that all are resistant, the problem is that polymyxins have very poor penetration into the CNS. So my backbone is also lost here. So perhaps what I'll have to do here is that if I have to extrapolate the regimen of polymyxin plus sulbactam plus minocycline, try and use it as IV colistin plus intrathecal colistin plus high dose minocycline plus high dose sulbactam. Again, that's how complicated it can get. Amongst minocycline and tigecycline, the better drug to use for CNS infections is minocycline. If you look at intra-abdominal infections or skin and soft tissue infections, the penetration of tigecycline is very, very high. In the lungs, both are not that great, but minocycline perhaps has slightly better intra-alveolar concentrations than tigecycline. In the CNS, minocycline has slightly better penetration than tigecycline. And for bloodstream infections, again, which is the better one, it's of course minocycline, because tigecycline doesn't achieve any levels in the blood. After an hour, almost 99% of the drug goes and sits in the tissues. So which brings us to the last slide, I think. Yes. In which body sites do the following antibiotics penetrate poorly? Tigecycline, where does it penetrate poorly? In the bloodstream. So after an hour, almost 99% of tigecycline goes and sits in tissues. And which tissues? Usually the GI tract and skin and soft tissue. So for skin, soft tissue, bones, GI tract, it's an excellent drug. Almost done. For the urinary tract, tetracyclines are not great drugs. And for the CNS and bloodstream infection, again, tigecycline is not a very good drug. It came with a black box warning a few years ago that it might increase the mortality in VAP. Now that fear has probably been overstated, but again, not a drug which achieves excellent intra-alveolar concentrations anyways. Polymyxins, where do they fare poorly? CNS and pulmonary infections. These are two important sites. Pulmonary not contraindicated, of course, but pulmonary, the PD targets are much higher. And aminoglycosides, so abscesses, again, is a problem. Pulmonary concentrations are not that great. CNS concentrations are not that great. Biliary concentrations, interestingly, are also not that great. So when you have infections in these sites, aminoglycosides again become limited. So I'll summarize by saying that, you know, for Acinetobacter, always the most important thing, not just for Acinetobacter, but for any infection is what is my site of target? Because I want to achieve local pharmacodynamics. If my site of target is the lungs, then the way I look at polymyxins is very different. If my site of infection is, let's say, an intra-abdominal infection, the way I look at tigecycline is much more favorable than how I would look at it otherwise. So always consider the site of infections. Get accurate MICs for polymyxins. So automated MICs for polymyxins may not be accurate. So the best way to do it is a manual broth microdilution. Easier said than done. We have microbiologists in the panel. So a broth microdilution manual for polymyxins, because of various properties, is much easier said than done. Consider at least 2 agents when possible. So we talked about that combination therapy, but polymyxin plus meropenem likely offers no advantage over polymyxin monotherapy in the Indian settings. So do not extrapolate minocycline MICs from tigecycline and vice versa. The resistance mechanisms are different. So mino-resistant does not mean TG-resistant, and mino-sensitive does not mean TG-sensitive. So do not extrapolate the MICs of one from the other. So combination regimens containing polymyxins plus sulbactam plus or minus minocycline, tigecycline can be considered in our settings. In the drugs to look forward to for Acinetobacter, sulbactam, durlobactam, and cefderichol are 2 drugs, you know, in the next 2 or 3 years, which we will probably start using increasingly. Although I always say that the real test of an antibiotic is when it comes to India. So we'll see about that in a couple of years. But right now, in theory at least, these 2 look like the most promising drugs. So with that, I'll stop. Thank you so much for inviting me, and I'll take questions with your permission if there are any.
Questions from the audience? 1 or 2? Yes, sir.
Thank you for the excellent deliberation. I am a pulmonologist, and one dilemma which I always face that the report is showing resistance to everything. Can we consider levonadifloxacin here or absolutely not at all?
So sir, levonadifloxacin for Acineto is going to offer very little over the other fluoroquinolones. If you look at MRSA, then levonadifloxacin does offer much more than the other fluoroquinolones. So the way the resistance mechanism work, the gyrases and the topoisomerases, the gyrases especially, they are much better suited for covering MRSA, which is not covered by other fluoroquinolones. For gram-negatives, especially for Acinetobacter, there is hardly any difference between levofloxacin, ciprofloxacin, and levonadifloxacin. Again, it's just a different isomer of levofloxacin. So it was specifically designed to have 2 things: better MRSA activity and to have better biofilm penetration. These are the best settings in which you can use levonad.
Sir, a question from me. Whatever we read in literature was tigecycline is bacteriostatic. So do we give a very large dose to have its efficacy?
Yes, ma'am. So all tetracyclines are bacteriostatic, and that's why when you have a resistant Acinetobacter infection, tetracycline monotherapy is a bit risky. If you look at all cases in literature, there are almost more than 80 to 100 cases in literature which have looked into can we use minocycline monotherapy for Acineto. The success rate reported is around 70%. So tetracyclines by themselves are static drugs, and so whenever you have a sick patient, best used as combination therapy. About the doses recommended for tigecycline also are much higher. So something like 100 milligrams BD instead of the 50 BD that we use. The problem is that Asian patients are likely to be slow metabolizers for tigecycline. So our risk of hepatotoxicity, especially cholestasis and hepatotoxicity, is much higher when it comes to higher doses. So in theory, though we might like to use them, in practice it becomes difficult.
Thank you, sir.
Sir, role of cholesterol nebulization and intrathecal cholesterol versus polymyxin, along with injectable cholesterol or polymyxin.
Right. So, both are excellent questions. What the guidelines say is that you can consider nebulized colistin, but on top of systemic therapy. Unless you have tracheobronchitis, in which there are some very sparse studies though, but which have said that, using nebulizations can be enough. When this has been studied in the setting of larger studies, there are studies from East Asia which have looked into this. They have really found not much benefit when it comes to Acineto specifically. But if you look at the kind of constraints that we have, then as adjunctive therapy, definitely in our VAP patients, it's a good way of using it. Again, what doses are we using? The recommended doses for inhalational antibiotics are much higher. So if you look at a lot of the European data, they are using doses like 9 to 12 to even 15 million units daily instead of a lot of our hospitals use 1 million units TDS. So 3 to 5 million units TDS is what they are recommending as inhaled therapy. Again, of course, we all know with the right kind of nebulizer, with the right kind of equipment. So that's one part of it. When it comes to intrathecal therapy, the data is a little bit more for colistin as against polymyxins. The problem is that both colistin and polymyxin do cause local inflammation. And that's why there is a possibility of chemical meningitis. If you look at the consensus guidelines, they had compiled almost 250 cases of CNS gram-negative infections in which intrathecal polymyxins were used, and almost 10 out of them developed very frank and florid chemical meningitis. So that's a concern, and that's why going by the safety of the anecdotal data, intrathecal colistin is preferred over polymyxin. But that's not to say that you can't use intrathecal polymyxin, but generally the convention has been to use colistin over polymyxin. B.
In your ICU, do you use inhaled polymyxins? That is the first part. And if you do, because you do mention about the fact that colistin penetrates poorly into the lungs, so polymyxin B would be a better option. If you are using systemic polymyxin, and if you want to use inhaled polymyxin, then do you go with inhaled colistin? Because polymyxin is not available for inhaled preparation. So what do you do in case you are using this?
So usually we go for systemic polymyxin B with inhaled colistin, sir. But because that's just because of the fact that, like you said, polymyxin B is not available for inhalation use. Now colistin itself, like I said, does have poor pharmacodynamics in the lungs. So in that sense, when you have a VAP, you really want to use a good systemic drug also. So although it would be more sensible to use the same drug as IV and as inhalational therapy, the pharmacodynamics are such that polymyxin B is a better drug to use in the lungs over colistin.
So it still makes sense to combine two different drugs.
Yes. Yes. So there is a lot of aggressive marketing when it comes to EDTA-based products in India. So I would say that, you know, and it's not that something that I am saying. What the literature is saying that see, what do we use EDTA for? We use EDTA in the lab to identify class B carbapenemases. So it's in theory a good agent against carbapenemases which are belonging to class B. However, the journey from the lab to the bedside has not yet been traversed. So if you look at, there are several questions. One is that what's the dose of EDTA that we are using? Higher doses are recommended, but then higher doses means that we have to conduct very good safety trials because EDTA is a chelator. So the trials have to look at electrolyte imbalances. They have to look at a lot of things before we say that high doses of EDTA can be used. The second thing is that the disc is not standardized. So if you look at a lot of these companies, they have their own ceftriaxone EDTA sulbactam or meropenem sulbactam EDTA discs. Now the drug there is not standardized, and there are in vitro or there are experimental studies. Of course, we cannot publish this, but they say that, you know, the drug content is higher than what is recommended for discs. So that's one part of it. See, the problem is that no other country uses EDTA-based products apart from India. So a lot of these things are not standardized. Their data is very, very poor. If you look at last time, you know, one of the companies that manufactures EDTA-based products, they had, as a part of the National ID Society, we had a day-long meeting with them in which they had shown us all their trials on EDTA-based products. If you see the patients included in those trials, the data is very, very poor. They don't have enzymatic analysis. They have shown sensitivity for a lot of pseudomonas isolates. Now, it's very difficult to imagine a drug like ceftriaxone sulbactam EDTA working for pseudomonas, because even if EDTA kills your NDM, you still need something to kill your pseudomonas, right? And the answer is not going to be ceftriaxone or sulbactam. The data is published in very, very sketchy journals, so there is no PubMed index data there. A lot of these studies are in-house studies, so there is a lot of things that still need to go into these studies before we can start using EDTA-based products. At this point of time, if you ask me my personal opinion, in my hospital I have banned EDTA-based products on the formulary. But that's not to say that you should be such an extremist. If you are using EDTA-based products, definitely use them as a part of combination therapy. But I would say one thing, that there is a long, long journey before we can actually use them in an evidence-based manner.
Thank you, sir, for such an excellent talk. I think we need to reinforce this frequently. Thank you very much.